So feel free to add anything to our laundry list. You guys can type them in, or we can just talk about them right here, right now. Is there anything from either last week's discussion on hospitals or this week's discussion that kind of was confusing, or you want to talk about, review a little bit? This information was a little bit more straightforward, so it's okay if we don't have anything for our laundry list. Okay, we will go ahead and move into the second half of our hospitalization um, content. So last week we kind of talked about some of those key things that we have to do in the hospital. This week we're going to talk more about how the being hospitalized impacts the child specifically. Also, if all of a sudden you start seeing a black box instead of my screen, please let me know. Did we get some things on our laundry list? Okay. So let's look at the different types of healthcare delivery settings. We know we have inpatient settings, we have outpatient settings, some acute care, long-term care. No matter where we are caring for our patients, it is our responsibility as nurses to help create that positive atmosphere. So depending on where you're working, you might have some different job responsibilities. If you're in an office setting, you might be the one doing the telephone triage, telling people if they need to come into the office or if they need to go directly to the hospital. For our outpatient clinics, satellite clinics, we might be the ones doing those weekend and after hours cares. And then in the home health setting, we're going to be doing things like infusions, hospice, group therapy, uh, any of those treatments that our patients still require, even though they don't necessarily need that additional level of monitoring that we would get in the hospital. So last week we talked a little bit about preparing our kids for their treatments. Depending on their age group and their developmental levels, then it's going to change how we prepare them for the whole hospital experience or these invasive procedures that we're doing. So for infants in that trust versus mistrust stage, we're really relying a lot on parents to help comfort them, provide that security while we're doing these painful procedures. We can also use familiar objects. So if they have a security item like a blanket or a teddy bear, we can use those to provide comfort during that painful procedure. We can also use soothing techniques, distraction, and then obviously comforting them after we're finished with the procedure. So whether that be swaddling or a hug, whatever that comfort measure may be. For our toddlers, we're going to do a lot of the same things, but they are in that autonomy stage. So they're wanting lots of choices. They want to have control over the situation. So if we allow them to make choices and give them one direction at a time, we give them some of that control back and allow them to express that autonomy. They will be able to start to understand simple explanations of their procedures. So we do want to explain and make sure that they're understanding what it is that we're going to do with them. Remember, our toddlers and preschoolers have that unique fear of body mutilation or bodily harm. So we need to make sure that they have an accurate understanding of what it is that we're doing so we can alleviate some of that fear. This is where role playing with either a doll or a stuffed animal can be really good to allow them to understand the experience without actually having to touch them. They also benefit a lot from distraction. So whether that is having them blow bubbles to distract them while you're doing a procedure or letting them watch their favorite show to keep them distracted. Have you guys heard of Buzzy Bee for IV starts or lab draws? Anyone? So this is a distraction technique that we can use. It's this little device that you can put above your IV site or where you're going to draw labs, and it just sits there and vibrates. So the child feels the vibration, they don't feel your poke. So that's a great way to distract them. We have lots of those types of devices in the hospital to help with pain control and improving that experience, especially for these little ones. So Buzzy Bee is a great distraction tool, especially for IV starts and lab draws. And again, as soon as we're done, then we will provide those comfort measures after. For our school age children, they will benefit from being able to examine that equipment before you use it. So they have a lot of curiosity and they need that time to understand what it is that you are using and how you're going to use it. We want them to verbalize any fears that they have so we can clear up misunderstandings. We talked about the fact that sometimes our younger kids have a hard time expressing their feelings in words. So sometimes they might need to draw out what they're feeling or color what they're feeling if they don't necessarily have the words for it. And then our school age kids are going to like those small rewards. They're really looking for following the rules and doing good things. So a reward for their cooperation goes a long way, even if that's just a sticker or a popsicle, whatever that little thing might be. Our adolescents, they are getting ready to be responsible for their own medical care and advocating for themselves. So we need to make sure that we are explaining the procedure to them specifically. All of our interventions should be tailored to them so that we give them the opportunity to practice advocating for themselves and making those decisions while they still have the safety net of their parents being present. We also know that as they're going through all of these changes that happen physically in adolescence, that privacy is of the utmost importance to them. So making sure that we're closing curtains, closing doors, only exposing what we need to work with, choosing those appropriate sites for injections so that we're promoting that privacy. And then teaching them how to cope with painful procedures, making these decisions. As they're learning how to problem solve, these coping techniques are going to come in handy. Yes, Mallory.
Are we supposed to be seeing the PowerPoint right now?
Yes. What? Oh, it's frozen. Let's try again. Why are you frozen? Let's see where we're, why? Are you still, why is our Minty not? Okay, let me pause here just a minute. Okay, so we are going to speed ahead to where we were. Okay, so privacy for adolescents, teaching them about coping techniques are going to be important for promoting that independence. How our kids react to hospitalization is going to depend on a lot of different things. How old they are, how many times they've experienced hospitals in the past. Is this a brand new experience? Is this something they're familiar with? Was this an emergency situation where we just had to load them up super quickly? We didn't have time to prepare them? Or was this a planned admission that we had ample time to explain why they were going to the hospital, what was going to happen when they were there? Also, their general support system. Do they have family that can be at the bedside all the time? Or are parents going to be split between other siblings or their work schedule? And then their overall emotional health is going to dictate how well they handle being hospitalized. We know no matter what age you are, there is fear involved in being in the hospital of all those painful procedures that we do and fear of the unknown. Also, being separated from your parents. We know that a lot of parents can't be at the bedside 24/7 for their own mental health and well being, as well as their other obligations. So, all of these add additional stress to our children. So, how do we help our kids maintain that normal routine that they are used to provide that sense of security for them? You guys can type them in or shout them out. How do we keep that normal routine? First of all, how do we know what that normal routine is? Ask questions. What does it include? How do they like things done? What's their normal schedule? Anything that we can do to bring those things from home into the hospital setting is going to encourage them to have that sense of security, even if it's as simple as a security item or bringing their own clothes, wearing their own clothes, especially for an adolescent, that helps them maintain that sense of identity that they're striving for. So, asking lots of questions, implementing any little thing that we can from their normal home routine into ours. So, as promised, we're going to talk more about separation anxiety. So, this was your discussion question for this week. So, we see separation anxiety beginning at 6 months of age and it peaks at 10 months of age. So, that's when we see it kind of rear its head the most. We see it most pronounced in our toddlers. So, we see it kind of hitting that 10-month right before we reach that 1 year mark. And then it carries all the way throughout toddlerhood. The important thing to remember is that these kids go through all three stages of separation anxiety each time they're left. So it's not age related, but it's this cycle of events that happens every time they're separated from their parents. So, this initial stage of protest is where we have that really loud initial outburst. They're crying. Our infants may cry until they fall asleep because they're so exhausted. Our toddlers are going to be calling out for their parents, extremely upset, inconsolable. That is your protest stage. We can help them move through this stage by providing those consistent caregivers. So we have someone outside of the family that they have a trusting relationship with. We can do short goodbye rituals. Remember, we talked about, especially with our toddlers, that ritualism is super important for their sense of security. And then we can use distraction to help get them engaged with something else. We do want to make sure, though, that we are not providing that distraction as a way to allow the parents to sneak out. So if parents sneak out on the child while they're not paying attention, then that, or while they're sleeping, that can disrupt that trusting relationship and cause more harm than good. So we want to have those short goodbye rituals instead of just having the parents sneak out on them. So after that initial outburst, that protest stage, we have this stage of despair. And this is where we've stopped crying. Now we're really withdrawn, really sad. We don't want to talk to anyone. We don't want to play with anything. This is where those familiar objects can come in handy. It can give you a way to engage with that child, talking about their favorite toy or their stuffed animal. We can also use distraction here, um, reassuring the child that the caregiver is coming back, talking about something fun that they get to do when they do come back to kind of distract them, get them engaged. After they move through despair, they move to denial or detachment. And this is a coping mechanism that our kids use to deal with the emotional pain of their parents leaving. So they will completely ignore their parents when they return. They will be more interested in whatever they're doing, whoever they're talking to, and they're going to pretend like their parents don't even exist. So our job is to help rebuild that relationship. So maybe bring up that fun thing that they get to do now that their parents are back. Have the parents ask them about their day, what things they did, kind of help facilitate those discussions, so that we can rebuild that relationship and get them engaged again. We talked about all the fear that comes along with being in the hospital. We've got these invasive procedures that we're doing. We're disrupting your trust because we've got all these new faces coming in and out. It also threatens our self-esteem and our self-control. We take away pretty much all of your decision making. We tell you what to wear, we tell you what to eat, when you can get up, if you can get up. We take a lot of control away from you when you're in the hospital. So allowing our patients to make choices gives them back some of that control and can help rebuild their self-esteem, give them some of that self-control that they're looking for. So that's another reason why we want to incorporate as many familiar rituals as we can into their hospitalization. So all of this additional stress of being hospitalized can lead to regressions, and we've talked about these briefly, but this is where we are taking a backward step in our development and um, as a way to cope with the stress. So instead of drinking from a sippy cup, we are going to regress and only drink from a bottle. Or if we're fully potty trained, we might start having accidents again. We might refuse to walk and demand to be carried the entire time that we are in the hospital. Those are all going to be examples of regressions. The important thing to remember is this is just a stress response. This is their attempt at a coping mechanism. So as soon as we remove this child from this stressful environment and situation, they should go back to their normal level of functioning. So we don't want to punish these regressions. We just want to ignore them, let them do whatever it is that they need to during this time, and then praise that appropriate behavior. So if they're willing to take a sippy cup, then encourage that. Praise them for taking a sippy cup. But if they still will only drink from a bottle, just let them drink from a bottle, knowing that as soon as they get back into their home environment where they're comfortable, they'll go back to drinking from a sippy cup. So helping parents work through that and not get frustrated with their child making these little backward baby steps. So here we have our first critical thinking discussion. We've got mom of a 2-year-old that decides not to visit for a couple days because it upsets her daughter too much when she leaves. She says it'll be easier if she stays away until it's time for discharge. How do we respond to that? Do we want her to stay away until discharge? No.
No, we don't want her to stay away. We can tell her that it's normal for her to be upset.
Yep. Yeah, what's this child gonna feel like if her mom stays away this whole time?
Like
Abandoned?
abandoned.
Yeah, abandoned. Absolutely. This child is gonna feel abandoned. It's going to totally wreck that trust that she just developed. She's just moving into that second stage of she's just moved past trust versus mistrust. So definitely a bad plan. This is normal. This is separation anxiety. Unfortunately, mom is only seeing that protest stage, that initial outburst. So lots of educational opportunity here with easing that protest and then teaching her that it doesn't stop there. She does regroup. She does interact again after mom leaves. She doesn't scream the entire time that she's gone. So lots and lots of education here. We want mom to be visiting regularly. We want her to be involved in care. So let's talk a little bit more in depth about pain. So pain is whatever our patient says it is, and it happens whenever they say it's happening. So even our kids can be um, reliable when it comes to expressing their pain. They can express it both verbally and non-verbally. We do have to be careful because sometimes our kids will deny pain if they're afraid that we're going to give them an injection. So making sure that they understand that we're going to use either oral or IV pain medicine so they feel comfortable telling us that they're in pain. We also know that patients that have pain secrete higher levels of cortisol. They can have more compromised immune systems and experience more infections. They also show delayed wound healing, which is why it's so important that we are addressing this and assessing it frequently. So in order to do that, we need to use the right scale. So for our nonverbal patients and our infants, we are going to use an observational or behavioral scale that requires very minimal input from our patient. So we can use a FLAC scale, NIPS scale, CRY scale. These all give us observations that we can make using our assessment skills to figure out what this child's pain score is. I think most of us are familiar with our FACES scale. So this is appropriate for our 3 to 8-year-olds. And this just gives you these cartoon faces 0 to 10 that indicate your level of pain. We talked about last week being careful when there is color associated with these cartoon faces, that your child is not just picking out their favorite color. So using those critical thinking skills, making sure what they're telling you is matching what you are seeing. Another scale we can use with this age group is the poker chip scale. So I give you 4 objects and you give me back the number that correlates with your pain. So if you only give me 1 back, then it means you have mild pain. But if you give me all 4 back, it's the worst pain of your life. So that's our poker chip scale, again, with our 3 to 8-year-olds. 9 and above, we can do that number scale. We can, a lot of times it's still on with the FACES scale. So they get both scales to figure out what to reference. And then we touched very briefly on the Oucher scale last week. This is just like our FACES scale, but instead of those cartoon pictures, it has culturally specific photos. So the child can relate to how they would express pain a little bit better. As we are managing pain, we are going to start with those non-pharmacologic techniques. So things like drawing, imagery, distraction, relaxation, deep breathing, things like that. Cognitive strategies like thought stopping. So this is where a patient will say stop over and over in response to a negative thought until that negative thought goes away. Massage is extremely effective, even all the way down to our infant population, helps them relax a lot. Last week, we talked about the large role that our liver and kidneys play in metabolizing our medication. Depending on how mature those particular organs are, will dictate how we respond to these pain medications that we are giving. We need to make sure that we are treating our pain adequately so that our kids can focus on being kids, engaging with their environment, meeting those developmental milestones. If we're not treating their pain, then they're not going to be able to focus on anything else. So with pediatric patients, it is most effective to use a preventative pain control plan. So this is where we give low dose medication around the clock on a schedule instead of just using those heavy opioids as needed. So I'm going to go ahead and just preemptively give you acetaminophen every 6 hours so that I keep you under control. And then if you're still having breakthrough pain, then we can give you morphine or another opioid on top of that. So teaching parents about that response and helping them to assess their child's pain as well is really important. As we're looking at those medications that we frequently use for pain, acetaminophen is most commonly used for our mild to moderate pain. It is our medication of choice for that mild pain. We can also use our NSAIDs like ibuprofen or Motrin, but acetaminophen has typically the best response and the least number of side effects. So that's going to be our medication of choice. For our moderate to severe pain, so any type of surgical pain, fractures, traumas, we're going to go ahead and use opioids to make sure that we get good pain control. Anytime that we give an opioid, especially for the first time, we want to make sure that we have naloxone or Narcan on hand in case that they have an opioid overdose. The younger your patients are, the more drastic their response is. So making sure you just have that on hand just in case you need it. For our short surgical procedures, we rely on fentanyl because it has a rapid onset and a very short duration. So we don't get those long-term side effects that we do with an opioid. We also have topical anesthetics like your EMLA cream or lidocaine that we can use for those quick procedures, things like sutures, IV starts, lumbar punctures. We can use that all the way down to our NICU population, so everyone can benefit from that. With conscious sedation, we like to use this for procedures that happen outside of the operating room. And this is where we are giving IV drugs to impair the consciousness so our patients don't remember the experience, but they're still able to maintain those protective reflexes. So they can keep their airway intact, they can respond to directions, they can still move their body, but they're not going to remember the experience. So we will stay one-to-one with these patients until they return to their pre-sedation level of consciousness. So they will be alert and oriented, their vitals will be stable, they'll be able to take things by mouth, respond to directions, and move their body safely. As we're in the hospital, we come into contact with people that English is not their first language or their preferred language. So we need to make sure that we are communicating in a way that is effective with them. So utilizing these language interpreters. These language interpreters are medically trained, so they are well-versed in medical terminology and how do we successfully convey that message to somebody that speaks another language. We do not want to use family members as translators because we have that risk of information being lost in translation. So that's why we use certified medical interpreters. Every healthcare delivery site is required to have them by law available for our family. We also have to be very careful about those nonverbal interactions that we have, understanding what is acceptable based on the patient's culture so that we can decrease that level of anxiety. So things like personal space, smiling, eye contact, touch can all be misinterpreted and convey a message that we are not intending. So we need to be very careful about our body language. Also, as we are tailoring our interventions and our education, we want to keep in mind what the patient's focus is. Are they really worried about the here and now and the immediate consequences of this hospitalization? Or are they more future oriented? Are they looking at long-term how this is going to affect the entire family, the entire community? That will help us to kind of tailor our interventions a little bit better. So if we are providing good culturally sensitive care, are we using the family to interpret or using medical interpreters?
Medical.
Yep, medical interpreters. How about always maintaining eye contact or following our cultural practice for eye contact? following that cultural practice. Sometimes eye contact is aggressive. How about staying in close proximity or respecting personal boundaries? Yep, we all have that bubble where we don't want people in. So, understanding everybody's comfort level with distance and proximity. How about touching as needed or always asking before touching? Yep, we definitely want to ask before touching and also explain the type of touch that we're going to do so that it's not misinterpreted. And then keeping a professional expression or always smiling. Yep, as much as we love to smile to be friendly, sometimes it can make a patient feel like we're not taking the situation seriously, or we don't think that it's sad that their family member is hospitalized. So not only do we have to worry about our child's reaction to being in the hospital, but they come with parents and family members as well. So we have to understand that they have their own experiences that are attached to this on top of what their child's going through. So they may ventilate their feelings, their stress. We might see them coming off angry, crying, hostile body language. They may be yelling at us. Not necessarily anything that we have done, but it may just be a response to their child being in the hospital, causing stress, and then their own experiences in the past also weighing on them. So if they've had several negative experiences with hospitalization, they may carry that baggage on and transfer onto their child's hospitalization. So we need to acknowledge that their feelings are real. We can do that by restating what they're telling us, how they're feeling, that therapeutic communication, and then work together with them to figure out how to move forward and improve the situation. We can role model appropriate parent interventions and make sure that we include them in that plan of care. They know their child the best. So we really want to keep them involved. So we need to meet the emotional needs of the entire family. We also need to help them to um, explain information to their child in an age appropriate manner. So teaching them how much is too much to share, what causes undue fear for their child, providing them opportunities to role model, play with things they might see, also explaining time in a way that they understand. So that's the biggest struggle that we have with pediatric patients is explaining time to them. So if we tell them 2 o'clock or 30 minutes, those do not resonate with them at all. We have to tell them things like after lunchtime or after your nap, or the procedure will take as much time as your favorite TV show. So explaining in a way that they understand before they have that logical, concrete thought. We know that hospitalization in general is frustrating. We might have that separation that we feel from our parents. We change your daily schedule. We take you out of that nurturing environment that you're used to. So we do need to make sure that we are encouraging parents to be at the bedside, taking advantage of those liberal visiting hours. They know their child the best. They'll catch those really minor clues to changes in their condition. It also provides our children with a sense of security. And we want to use those consistent caregivers. We've talked about this at length. It develops that trusting relationship. We can balance the good and the bad experiences. It gives parents a little bit of relief, somebody that knows their child, understands their routine. They don't have to explain themselves over and over again. We also have to make sure that we are providing opportunities for our patients to meet those developmental milestones. So especially our sensory motor activities, allowing them to have those opportunities to play. We're going to skip that one. As we're looking at ways to improve our nursing care, we want to encourage early discharge as soon as possible. So as soon as our patients are stable enough to not require the intense monitoring that we have in the hospital, we want to get them back to their home environment. They're going to thrive in that home environment. So even if that means we have to send them home with home care, so they can still have medications or infusions or lab draws in that home setting where they can thrive. We want to be flexible so we can provide that happy, relaxed environment. We want to work together with the families to ensure our best outcomes for everyone. We'll talk about choosing age-appropriate roommates a little bit later. We want to encourage those parents to be at the bedside as much as possible. So we also refer to that as rooming in, is another term that you might see. And that just means that parents can be at the bedside 24/7. Especially with our adolescents, we want to help them work through understanding the impact of their disease, those long-term consequences, problem solving, thinking about outcomes. We want to encourage them to make those decisions and practice their self-advocacy skills. We're going to keep going. When we're trying to choose when we're trying to choose roommates, we want to make sure that we're pairing somebody that is age appropriate and disease appropriate. So we don't want to put an adolescent and an infant together. The infant is going to be crying, is going to wake up the adolescent. They also can't interact with each other, and that we know that socialization and peer interaction are essential for adolescents. So making sure that we're going to pair them with somebody their own age so that they can have those peer interactions. We also probably don't want to put them right next to the nurse's station. They're going to feel like we're constantly looking at them, disrupting their privacy. So they're going to do a little bit better towards the back of the unit where they can have that privacy. Our infants are going to be more appropriate to be right outside the nurse's station because we can keep a close eye on them. We also don't want to pair patients together that could compromise each other. So you're not going to put an immune compromised patient next to a patient that has MRSA. That's going to be a bad situation. So making sure we're taking into consideration our disease process and our age and development. With adolescents, we also have to look out for some legal caveats and confidentiality things that come up. So emancipated minors are people that are under 18, but no longer are under their parents' authority. So they are able to consent for their own treatments. They are able to make decisions for themselves without the input of their parents. They also control the information that is released about them. So it's really important that you understand your specific state's rules when it comes to the information that we can release about minors and any fine details about those emancipated minors. If you are married under the age of 18 or in the military, you automatically get grandfathered in as an emancipated minor, even if you don't have legal documentation for it. As we talked about when we looked at Eliza Simmons last week, we want to make sure that we're doing our discharge planning as soon as they're admitted to the hospital so that we can provide that information in little chunks along the way so we can improve their retention of that information. Anything that is expected of them at home should be provided in writing so that they can reference it later. We also need to provide some anticipatory guidance, preparing families for behavioral problems that might creep up as this child is reintegrating back into the family, getting back into their normal routine. As we are discharging patients, we want to provide that final discharge note to wrap everything up in a nice, neat little bow, kind of this nice handoff explaining the child's status as they left our care. So we're going to chart about who we discharged to, how we knew that was the right person to send them home with, how they left, what they looked like, their vitals, their overall assessment, and any discharge instructions that we gave in writing. That just provides a nice snapshot so that you have that final look at your patient, final assessment. When we send kids home with home care, it can either be an acute or a chronic condition that they're going to have long-term care for. We're relying on those home health agencies to provide that extra level of care that they need to make them successful at home. We can also provide respite care for our patients with chronic illness so that parents have an opportunity to do some shopping, run errands, take care of themselves without having to worry about their child being safely taken care of. And then we also want to check in with the school, making sure that they understand any new medications, new treatments that will be required when this child comes back to the school environment. Okay, guys, that is it for our PowerPoint today. I do want to go over some things that are coming up. You guys have done great with your discussion posts. You all did well on your NCLEX questions for week 3, so no issues there. And you guys are finished with your exam. Again, those scores will come out tomorrow afternoon.